This recording will discuss the information in Chapter 6 regarding neoplasias. We're going to start the discussion with talking about characteristics, differences of benign versus malignant neoplasms. So, unlike in normal cellular adaptive processes, like we talked about earlier, things like hypertrophy, hyperplasia, neoplasms do not obey the same laws of that normal cell growth. They serve no useful purpose. They're not occurring in any response to an appropriate stimuli, and they continue to grow, often at the expense of the host. So tumors are a mass of cells due to overgrowth. And neoplasms fall into two separate categories, malignant versus benign, and we'll talk about the differences kind of between the two. We also have some naming conventions that we use for tumors. They're named typically by adding the suffix OMA to the parenchymal tissue type from which the growth originated. So here are some examples. You can find a lot more on page 95, table 6.1, but some of these naming conventions also help you look at whether or not a neoplasm or a growth, if it's being discussed maybe in an H&P or in some paper we're going to chart, you can understand whether or not that is a benign or a malignant neoplasm based on its naming convention. So things like an adenoma is a benign tumor of glandular epithelial tissue. So we added OMA to the parenchymal tissue type, which was glandular epithelial tissue, to name that benign neoplasm. The same tissue, that same glandular epithelial tissue, if we have a malignant neoplasm or a malignant growth, it's an adenocarcinoma. So a little different nomenclature for something that is a malignant neoplasm. A carcinoma is a malignant tumor of epithelial tissue, so something like a squamous cell carcinoma. An osteoma, benign of bone tissue, but osteosarcoma is a malignant tumor of the bone. So you can kind of see how those are different in our naming conventions for benign versus malignant. Again, you can use page 95, table 6.1 to see some other examples of how that looks. So this is another thing I'll mention about regarding your reading. Summarized in table 6.2 are all of these factors that differentiate benign versus malignant neoplasms, so how they are different. So that would be a good spot to reference for you. But just very generally, benign and malignant neoplasms differ in their cell characteristics, in the way that they grow, in how fast they grow. They differ in their potential for metastasizing or spreading to other areas of the body from their original location. They differ in their tendency or ability to cause tissue damage, and they differ in their capacity to cause death. So we'll look at that a little more closely. So with benign neoplasms, these have a rate of growth that is typically slow and progressive. They may have periods where they come to a complete standstill. They may even regress or shrink during that growth period. They grow by expansion, so they just kind of get larger and larger. They are non-invasive, meaning they don't invade or kind of dig their way into surrounding normal tissue. And they're typically encapsulated. So there's usually kind of a capsule that sort of surrounds and demarcates that tumor. Benign tumors do not spread by metastasis. And usually the cells are well differentiated. And when we say well differentiated, that means that those cells still resemble the cells of the tissue of origin. So if we're talking about that adenocarcinoma that we saw, or that osteoma that we saw earlier, if in the case of an osteoma, for instance, which is a benign tumor of bone, that tumor's cells would still look like bone cells, very similar to their tissue of origin. Another major difference between benign and malignant neoplasms is that these benign tumors do not usually cause death unless their location or size interferes with vital function. So if it's perhaps a benign tumor, but it's in the brain, right, and it's growing at a rate that's starting to impinge on important structures in the brain with nowhere to grow, that is something that could cause tissue damage or death just because of the space issue. But in general, they don't. We'll compare that to malignant neoplasms. So these are cancerous neoplasms or cancerous cellular growth. So the cells within a malignant neoplasm are typically undifferentiated, meaning they don't bear much resemblance anymore to the cells of origin. So going back to those tumors of the bone, for instance, if now we have an osteosarcoma, those cells look less and less like bone cells. They change as they grow to not look anything like the original cells. Their growth is really variable. It depends on the amount of differentiation. So the more undifferentiated, the more those cells start to look different than their original cells, the faster that they'll grow. These often grow by invasion, so they infiltrate or kind of dig into the surrounding tissue, and that's going to become kind of important later when we talk about some of the other characteristics of malignant neoplasms, some of the clinical manifestations, but just know they're typically very invasive. They kind of dig themselves into that surrounding healthy tissue around the neoplasm. And they also are able to gain access to blood supply, to lymph tissue, and that helps them to be able to metastasize to other areas of the body. So they will spread. And malignant neoplasms also are capable of causing tissue damage and eventually death, unlike benign neoplasms. So again, malignant neoplasms, a little bit more about them. They damage tissue by compressing and outgrowing their blood supply. And that starts to cause ischemia and tissue injury to the cells around them. They grow so fast that they start to outgrow the blood supply available. They pull blood supply from normal tissue, and we start to get tissue injury and cell death and ischemia on that surrounding tissue. Many malignant neoplasms are able to secrete hormones or enzymes or toxins that cause inflammatory injury to tissue as well. There are two types of malignant neoplasms. We have solid tumors, or we have hematologic or malignant neoplasms of the blood or lymph. So solid tumors are initially usually confined, but then typically metastasize. And different types of cancers have different rates of metastasis. Some take a while to metastasize and don't spread very easily depending on their site of origin. Other solid tumors may metastasize well before someone even knows that they have a solid tumor forming. So just a lot of variation in that rate of metastasis. And a lot of the time, the rate of metastasis that you see with cancers also speaks to how difficult those cancers are to treat and how deadly they might be. Those that tend to metastasize very quickly, often before people even know they have a malignant neoplasm, tend to be the more difficult cancers to treat. Hematological cancers, because they involve the blood and lymph, those are already disseminated at the start. When we talk about metastasis in a minute, you'll note that one of the ways we metastasize is that those tumor cells sort of get themselves into blood and lymph and spread around. In the case of a hematological neoplasm, they're already there. So they are disseminated and spreading from the start. So some other individual characteristics of cancer cells. There's really two main features at play here. One is what we call abnormal and rapid proliferation, meaning they're growing really quickly. Those cells are dividing and growing really quickly, and they're as they do that, that growth is abnormal, meaning those cells are looking less and less like their original cell type. And the other is that loss of differentiation. That loss of differentiation, that change, is called anaplasia. So that's the term we use for that. Cancer cells usually have a large number of cells in mitosis at any given time because they're growing so quickly. We're not going to get into treatment too much, but that's one of the characteristics of cancer cells that makes them somewhat amenable to some of the treatments that we use. So things like chemotherapies are really good at attacking cells that are growing really rapidly, and that's why they work on cancer cells. Same can be said for things like radiation therapy. Radiation can selectively kill cells that are rapidly proliferating or dividing or have a high rate of mitosis. So that's why the treatments really are chosen for cancers because of that rate of growth. Um, Cancer cells tend to be very genetically unstable, meaning that they are subject to high rates of mutation. Remember that DNA tends to be very stable in cells. The same can't be said for the genetics of a cancer cell. They grow independent of growth factors. Um, Normal body cells do not proliferate or divide in the absence of growth factors. Normal cells need some kind of signal to say, grow and divide. Cancer cells don't need that signal. They do it independent of those growth factors. Another thing is that when normal cells reach a certain level of density, meaning a certain number of cells within a space, they stop growing. We sometimes call that contact inhibition because when normal cells start to kind of bump into or contact other cells, they stop growing. That's important for things like normal wound healing, right? If we were trying to heal a wound and we had cells that were starting to fill that space and they just grew without any checks and balances, right? They would just kind of outgrow that wound. But instead, they start to bump into each other, and that density starts to inhibit their growth. Cancer cells do not have that same mechanism. They are not density dependent. So they will continue to grow regardless of the fact that they're just really kind of filling up and bumping into each other in a certain space. Another thing is that normal cells in the body tend to be anchored to something, whether it's anchored to another cell or anchored to some sort of extracellular matrix. To live and grow, normal cells need that anchoring to survive. Cancer cells don't need that. So they have what we call low cell-to-cell adhesion, low anchorage, and low cell-to-cell communication. That's another one of the factors that makes it more easy for them to metastasize because they do not need to be anchored to anything. And another thing that's different between cancer cells and normal cells have a limited lifespan. There's a limited number of time a normal cell can divide, and it's not going to go beyond that. In a cancer cell, they can just grow and divide an infinite number of times. There is no limitation to their lifespan. So we'll talk a little bit too about how cancers spread, remembering that these malignant neoplasms can metastasize. There are three significant ways that cancer cells can metastasize. One is by direct invasion and extension. Um, so most cancers will synthesize and secrete enzymes that start to break down the proteins of normal tissue surrounding them, and that helps to allow them to infiltrate, invade, and penetrate surrounding tissues. There's no line of demarcation between malignant tumors and normal tissues like there is in a benign neoplasm. They're just growing their way, invading and extending into that normal tissue. And so that's one way that they can metastasize. Another is by seeding of cancer cells into body cavities. So when we talk about body cavities, we're talking about things like the peritoneal cavity, which is that space in the abdominal area. They can also spread themselves into pleural cavities, which is the space between the lungs and the um, pleura that surrounds it. They can get into the pericardial cavity, which is the space between the heart and the pericardium, which is the sac that surrounds the heart. They can get into joint spaces, anywhere where there's kind of a body space. If there's cancer growing there, it can seed itself, or little cells can break off and get themselves into that space. The most common place where that happens is usually the peritoneal cavity. That's the most common space where we see cancer cells kind of seed themselves. So one common cancer that really tends to seed itself into the peritoneal cavity is ovarian cancer. So there's ovarian tumor growth on the ovaries within that abdominal cavity. Cells break off and seed themselves in the peritoneum. Another way that seeding happens, it's also a potential post-op complication. When we go in and surgically remove cancer cells, we can also sort of help those along to break off and sort of seed themselves. And the final metastasis mechanism is spreading through the blood or lymph pathways. Um, in many types of cancer, the first evidence we have of, excuse me, I'm going to keep talking on this slide. Often in cancer, one of the first pieces of evidence we have of cancer being even there is finding metastasis in lymph tissue. So the final way that we metastasize is we have malignant neoplasms that are growing, and they've created blood and lymph supply for themselves. And the blood and lymph supply, the venous supply, and the lymph supply is taking cells away from the tumor site, and now they're seeding them and allowing them to spread. Okay, so the next thing we're going to talk about is some of the genetic and environmental etiologies of cancers themselves. So we'll start by talking about the different genes and how they control cell growth and replication, and how that relates back to some of the characteristics and things that we saw as that tumor growth starts to occur. So most cancer-associated genes can be classified into two broad categories based on whether gene overactivity or underactivity increases the risk of cancer, or are we overactivating a gene, or are we underactivating a gene that was that's function was to prevent kind of that overgrowth of a tumor. Okay. So, proto-oncogenes are normal genes that are capable of mutating to cancer-causing oncogenes. Okay? And those cancer-causing oncogenes kind of turn on some of that abnormal cellular growth that we see in malignant neoplasms. We also have tumor suppressor genes, and normally those genes inhibit that rapid cell proliferation, and these become inactivated, causing unregulated growth. So again, we have kind of two broad categories. One, a gene that's turned on to allow that rapid proliferation, and one that is a gene turned off that now stops that sort of inactivation of unregulated growth. We also have genes that control programmed cell death or apoptosis. Apoptosis, that programmed cell death, is important to keeping sort of cells in check and preventing a lot of that rapid proliferation. So apoptosis is a normal function within cells themselves, again, to prevent that rapid proliferation. Cancer cells, that's turned off, and they do not undergo apoptosis. So there is no programmed cell death to prevent all that rapid overgrowth. Another genetic change that we see in cancer is genes that regulate or repair damage to DNA are not functioning properly. In a normal cell, we have a lot of different mechanisms that come in, and when we have DNA mutations, they come in and maybe splice that out or go through a lot of different processes to repair DNA. We don't see that in cancer cells. So they go through, remember we said that genetically they're very unstable. They're very prone to genetic mutation and change. And all of those changes, those mutations that are now kind of just unregulated and unchecked, cause a lot of that unregulated growth. So that's a lot of the genetic reasons why we see those individual cell characteristics of malignant neoplasms that we just talked about. So, how do those genetic changes sort of lead to the abnormal cells that we see within cancer? So there's several steps involved in that transformation of a normal cell. Here's my little normal cell up here into a cancer-causing cell. So the first step is what we call initiation. So during initiation, my normal cell is exposed to a dose of some kind of carcinogenic agent, and that makes them more susceptible to some kind of malignant transformation. So here's my normal cell. There's a carcinogenic agent, whether it's a chemical, whether it's radiation, whether it's a virus, and we're going to talk about some of those etiological mechanisms in a moment. But they cause initiation, or that exposure causes that cell itself to be more susceptible to malignant transformation. So again, that's called initiation. Okay. And so now we've got maybe some normal cells, and now we've got some cells that have some sort of genetic mutation caused in that initiation phase. The next step is what we call promotion. Promotion is unregulated, accelerated growth in an already initiated cell caused by various chemicals and growth factors. So again, now we've got that mutated cell. That mutation activates maybe some of those oncogenes that we talked about. And now that cell starts to have this rapid, unregulated growth. We call that promotion. So cells are growing, going through a lot of mitosis, and mutating as they do that. Okay. Progression is the final step of the process. And that manifests when tumor cells have acquired these malignant phenotypic changes that promote that invasiveness. They give it the ability to metastasize. They now have all of those autonomous growth tendencies. They're very genetically unstable. And so now we've got a malignant tumor. We also have hereditary predisposition to cancers. We've linked up to about 50 different types of cancers to hereditary predisposition, where we see an increased susceptibility to cancer traveling in families. So things like the BRCA genes in breast cancer, ovarian cancer, we know travels in families. You know, again, 50 different types of cancers in families. So that's one host factor that can lead to cancer, is those hereditary predispositions. We also have hormonal environmental factors that can lead to cancer. We know that things like, especially breast cancers, prostate cancers, seem to be, their growth is promoted by the presence of things like estrogen or androgens. So sometimes in treating some of those hormone-initiated cancers, one of the things we do is maybe block estrogen in women with breast cancers, or block androgens in men with prostate cancers. We also know of a lot of different carcinogenic agents. A carcinogen is an agent capable of causing cancer. So if you remember back to the last slide, right, it's that carcinogenic agent, or that chemical agent, that will predispose a normal cell to being able, it'll initiate a cell through that process of change. So a lot of the time carcinogens are lifestyle risk factors, so things like smoking or dietary factors, alcohol consumption. We know that alcohol is carcinogenic. It's linked to many different types of increased risk of cancer. One prominent dietary factor that we often talk about here are food preservatives. We've linked those to cancers. Most of these chemical carcinogens are dose dependent, meaning the more of them that someone is exposed to, the more likely their risk of cancer formation. Radiation is another known carcinogen. Radiation exposure is tied to things like leukemias. We are all aware of the radiation exposure from the sun, and it's linked to skin cancers. We also have what we call oncogenic viruses, so viruses that seem to turn on those oncogenes. So some examples here, the 4 that we're aware of are human papillomavirus, Epstein-Barr virus, hepatitis B virus, and human herpes virus 8. That is the virus that can cause what we call Kaposi sarcoma, which is a neoplasm that we see in people with the AIDS virus. Immunologic mechanisms. We understand that the development of cancer might be associated with impairment or decline in the surveillance capacity of the immune system. One of the functions of the immune system appears to be to kind of seek out some of these mutated or changed cells and destroy them. If we have reduced immunity, we have a reduced ability of that system to function. And so people with reduced immune function, whether it's older people or whether it's people with general reduced immunity, like we see in HIV and AIDS, are more prone to the development of malignant neoplasms. And the final thing is obesity. There appears to be a strong and consistent relationship between obesity and mortality from all cancers among both men and women. So next we're going to talk about some of the clinical manifestations or signs and symptoms of cancer. So the first one we're going to talk about is sort of a local clinical manifestation, which is changes to the tissue integrity surrounding some of these malignant neoplasms. So these neoplasms often compress or press down on blood vessels in the area, or they erode blood vessels. So this can cause things like ulceration and necrosis to surrounding tissue. It can cause bleeding and hemorrhage. So often one of the first warning signs of cancer is blood or bleeding, and where that bleeding occurs often speaks to where that neoplasm is. So if we're seeing blood or bleeding in the stool, we relate that to colorectal cancer. Um, so when we talk about some of the diagnostics of cancer in a moment, one of the things that we look for in colorectal cancer is blood in the stool. Other things like wounds that won't heal are often associated with skin cancers. Compressed viscera within the bowels may point to colorectal cancers. They might cause obstruction, right? Another thing we see with changes to tissue integrity is what we call development of effusions, and that's a buildup of fluid, usually like thin, clear fluid, and that fluid can build up in the pleura, so that's the space between the lungs and the pleural sac. It can build up in the pericardium, or in the pericardial space, which is the space between the heart and the pericardial sac. And one of the really common places that we see tissue, or fluid build up with cancer is in the peritoneal space. So in that abdominal cavity, we see people develop fluid buildup or effusions within that space. So some of the systemic manifestations or some of the clinical manifestations we see system-wide with cancer are listed here. The first one is anorexia and cachexia. Cachexia is weight loss and wasting of body fat and muscle tissue. It often leads to profound weakness, further anorexia, which is significant loss of appetite, and anemia. So anorexia, which is again reduced food intake, and abnormalities of taste are really common in people with cancer. And they're often accentuated or exacerbated or made worse by the treatment methods we use. So things like chemotherapy, radiation make those things worse. And so we would anticipate, a certain amount of weight loss and things based on the anorexia. But the weight loss and the tissue loss that we see in cancer far exceeds the amount that we would expect in anorexic states. And it's usually in states of like regular starvation, absent cancer, where we see lack of food intake, we see weight preferentially lost by way of fat loss. But in cachexia related to cancer, the loss is both from fat tissue and significantly from skeletal muscle tissue. So we really lose both, a lot more than what we see in typical starvation. Another clinical manifestation is fatigue and sleep disorders. So we often see difficulty sleeping and insomnia. But cancer-related fatigue is often an early warning symptom of malignant disease, and it is reported in more than a third of people at the time of diagnosis. So a lot of the time when people are diagnosed, the initial symptom that they report coming in is just this overwhelming fatigue. And the symptoms often, even after treatment is over for cancer, they last months to years after treatment. So fatigue is a sort of long-lasting complication. And fatigue is different than like just kind of normal tiredness. So in normal tiredness, if you rest, it's relieved. In fatigue, that tiredness persists even beyond rest. Another systemic manifestation is what we call perineoplastic syndrome. A lot of tumors will secrete inappropriate hormones. So one of them is antidiuretic hormone, which we'll talk about more when we get to things like fluid and electrolyte balance. ACTH is a stress hormone that's often released directly from those malignant neoplasms. Um, the tumors themselves can release circulating hematopoietic um, hormones. These are things that can affect things like blood coagulation. So in patients with malignant neoplasms, we tend to see a lot higher risk of the development of clots, especially in the venous system, because of these um, things being released from the tumors themselves. They also can release neurological and dermatological factors. So we see things like skin problems, neurological deficits, again, increased clotting. Those are common manifestations that we see in patients with cancer. And the final clinical manifestations I'll note are again anemia. So reduced red blood cell counts are very common in patients in cancer. Increased infection risk is very common in patients with cancer. And the final clinical manifestation is pain, especially in later stages of cancer. We have pain that is usually significant and often very difficult to treat. Next, we're going to talk about different screening and diagnostic methods. We're really going to focus there. I'm not going to talk too much about treatment at this point. So the first thing I'll say about diagnostic measures for cancer and detections and screening, many cancers do not have any early detection methods. So as I mentioned earlier, they can metastasize very early. So one of the big areas of research within cancer itself is to develop more sensitive screening methods like sensitive tumor markers, because the cancers that we tend to have better success in reducing things like morbidity and mortality are the cancers that have good early screening and detection methods. So secondary recognition for early recognition in the asymptomatic, that is the definition of screening. So when we're screening, we're looking for um, cancers in people who have not developed any symptoms of cancer yet. Okay. So oftentimes these screenings can be observational, like going into the dermatologist and having them do a complete skin check, looking for any signs of skin cancer. When we go to the dentist, they often do a check or an observation within the mouth, looking for any signs of cancer. External genitalia, we can look for any signs and symptoms of things like penile cancers, vulva cancers, directly observing for those. There are also a lot of screenings that involve what we call palpation. So self breast exams or breast exams that happen within the physician's office where we're feeling for tumors. Thyroid exams where we palpate the thyroid, feeling for any abnormal growth. Um, Prostate exams, we palpate the prostate. We call that a DRE or digital rectal exam, directly palpates the prostate, feeling for any abnormal growth. We can palpate lymph nodes. Rectal exams, again, feeling for prostate or for any other abnormal growth of cancer within the rectum. And we also have laboratory tests and procedures that fall into this screening method. So things like pap smears, where we collect cells from inside the cervix to look for abnormal growth. Colonoscopy, where we go in with a scope and visualize the inside of the colon looking for any cell growth. Mammography, which uses X-ray to look for any tumor formation or growth within the breast tissue. PSA is something called prostate-specific antigen. This is a serum marker that's relatively sensitive for prostate cancer. So we are able to use that serum marker or blood test to monitor for prostate cancer. And this is a common screening method we use in men. And the final screening method is what we call fecal occult blood test. So this is looking for colorectal cancer, that's invading and causing bleeding within the colon or the rectum that we see as blood inside stool. So fecal occult blood testing is directly testing feces or stool for the presence of blood. Okay. Some other notes about diagnostic tests. So we're moving on from screening to diagnostics. So we have a lot of different tumor markers that we can use in diagnostics. So we talked about tumor markers like PSA being used for screening, but we have a lot of additional tumor markers. One that I'll mention is something called CA125. And CA125 is a blood test that can indicate the presence of different types of tumors. Things like ovarian cancer is linked to CA125. But we don't use that type of tumor marker as a screening method because there is a really long list of non-cancerous conditions that can also elevate something like a CA125. So just because someone has an elevated CA125 does not necessarily mean they have cancer. So something like that as a tumor marker is not a great screening method because it would give us a whole lot of what we call false positives. We would see a lot of elevated CA125 in individuals who do not have cancer. But we can use it as more of a diagnostic tool. So if we detect the presence of perhaps an ovarian growth, we can also look at CA125 levels. And if they're also elevated, then we're more apt to think that we maybe have a cancerous growth. We would probably also continue with things like biopsy or further diagnostics. But these work better in that area of diagnostics than as a screening method. We also often use some of these additional tumor markers, and again, there's a long list of them. I'm not going to go into too many of them, but we can also use the maybe less what we call specific tumor markers for monitoring treatment. So if we have a patient potentially with, again, maybe ovarian cancer, and they have a dramatically elevated CA125, if we initiate treatment with maybe chemotherapy and radiation, we also maybe periodically are monitoring that CA125 and hopefully watching it drop as that treatment is working on that ovarian cancer. We also have a lot of cytological and histological methods for cancer diagnosis. So we talked about pap smear. That pap test, or looking at the cells themselves, is what we call cytology. We're looking for any undifferentiated or changes to those cells. We do a lot of tissue biopsy. So if we note an area of abnormal growth, maybe on a screening, then we would go in and biopsy that abnormal growth, right? So if we did a palpation screening of a thyroid, for instance, and we noted an abnormal growth on palpation, we would then go in and do a tissue biopsy where we would insert a needle into that abnormal growth. We would remove cells and take them for cytology and histology to look for undifferentiated or changes that might indicate malignant neoplasm. Okay. We have other things, immunohistochemistries, microarray technology. I'm not going to go into those too much. Really just focus on some of those tumor marker pieces and the cytology and histology methods that we just mentioned. The final thing we're going to talk about is some differences between childhood cancers and adult cancers. So cancer in children, relatively rare. About 1% of all the malignancies we detect every year in the United States are in children. So far fewer cancers show up in kids than in adults. Although they're rare, cancer still remains the second leading cause of death among school-aged children in the U.S. Some of the common cancers that we see in kids: leukemias, non-Hodgkin's and Hodgkin's lymphomas, bone cancers like osteosarcomas and Ewing sarcomas. The overall survival rate for children diagnosed with cancers is about 85%. So we do a fairly decent job of reducing mortality in children. So again, we'll just talk about some of the differences between childhood cancers and adult cancers. Most adult cancers are epithelial cell in origin, meaning most adult cancers originate from epithelial cells. But most childhood cancers usually involve the hematopoietic system, so blood and lymph, or the nervous system, or different connective tissues like soft tissue or bone. We also see more childhood cancers develop maybe in the kidneys. The reason for this, or the reason we see this, is that mutations are often that cause cancer are often inherited or heritable from the germ cells. So remembering back to some of our conversations about mutations that can happen during meiosis or when we're forming germ cells or sperm or egg cells, if we have genetic mutations that happen during that process, those mutations then are passed to the embryo. And that's what we mean when we talk about heritable forms of cancer. We're getting those directly from mutations that have formed within the germ cells. Other mutations that we see in childhood cancers happen during embryonic development. So there's some kind of mutation that happens while that embryo is developing. We usually term those types of cancers as blastomas. So things like neuroblastoma falls into that category of a mutation that happens during embryonic development. When we talk about heritable forms of cancer, again, those cancers that are coming directly from mutations in germ cells, they usually have a much earlier age of onset. So that's why we see them in childhood. They have a higher frequency of multifocal lesions in a single organ. So if we have maybe a kidney cancer that's developing, we'll have multiple lesions within that kidney itself. And they often have bilateral involvement of paired organs or multiple primary tumors. So again, in an adult cancer, we usually have maybe one primary tumor that develops. So adults get kidney cancer. So usually what we see is maybe one solid tumor that develops within a kidney, just one kidney, even though they're a paired organ. In children in that kidney cancer, we would see potentially multiple tumors developing, and we'd see them probably in both kidneys. Because again, that mutation happened really early on in embryonic development. And so the cells that are causing that are dispersed in both kidneys, right? And so can cause mutations in both at multiple sites, right? So again, common solid tumors of childhood, so within the brain and nervous system, neuroblastomas, which are those embryonic nervous system tissues that we see, something called a Wilms tumor, we'll talk about those later, rhabdomyosarcomas, so tumors in the muscle, embryonal sarcomas, retinoblastomas, these are embryonic based cancers that we see in the eye, osteosarcomas, so that's cancer of the bone. Ewing sarcoma is also another distinct cancer that we see in bone tissue. So another distinction within childhood cancers is that now we're treating cancer in young children. And so the incidence of things like long-term effects of radiation and chemotherapy are more significant sometimes in children than we see even in adults. So long-term effects of radiation, radiation therapy poses risk of long-term effects for survivors of childhood cancers. The long-term effects of radiation therapy are influenced by the organs and tissues that are included in the treatment field. When we treat someone with radiation, we usually try to aim that radiation directly at the cancer we're attempting to treat. We do that to try to reduce the amount of systemic or widespread long-term complications that we see. So the amount of long-term side effects we see is usually dependent on the amount of radiation dose, how large that treatment field needed to be, where that treatment field was. Usually, is what speaks to how those long-term complications look. So there's increased risk from radiation of things like melanoma or skin cancer formation. Again, both melanoma, squamous cell carcinomas, and basal cell carcinoma. Again, because we're applying radiation directly to the skin tissue itself, we can see genetic mutation in the skin tissue that can predispose to skin cancer later. Musculoskeletal changes are common after radiation. Again, a lot of the cancers that we see in children are in like soft tissue, like muscle, or in connective tissue, like bone. If we're directly radiating that tissue, we see musculoskeletal changes afterwards. Um, so that might lead to things like pain or altered musculoskeletal function throughout their lifespan. We also see long-term effects of chemotherapy. So chemotherapy poses risk of long-term effects for survivors of childhood cancers. So some potential changes that we see, so things like what we call gonadal injuries, so things like infertility or early menopause, pulmonary fibrosis, so changes to the lung tissue. It becomes what we call fibrotic or kind of stiffened. Um, in children who have been exposed to chemotherapy. We see kidney disease, we see cardiomyopathy because a lot of the time those chemotherapeutic agents are toxic to um, cardiac tissue. We see ototoxicity or damage to the ear, so we might see hearing deficits or changes. And neurotoxicity is also relatively common. So things like nerve damage. So we might see neuropathies or changes to sensation, maybe in the hands or the feet. Those are relatively common after chemotherapy.